I'm honored now to be able to introduce our keynote speaker for the day, Dr. Jerome M, the 20th Surgeon General of the United States. And when we met last year at the American Public Health Association meeting in San Diego, I was so impressed with his perspective and his commitment to dealing with equity, the substance use disorder and opioid epidemic, and so many other things. So I invited him on the spot to attend a conference that didn't exist, and he accepted. As I said earlier, we arranged the conference so that he could be here, and we know that he's a man who keeps his commitments, and we thank you for coming. Dr. Adams' motto as Surgeon General is better health through better partnerships. And he's committed to having strong partnerships in the public health community and also forging new partnerships in non-traditional partners, including business, law enforcement, and more recently with banking and with the economic communities. He's pledged to lead with science, something that we all have to really recognize is important these days. Yeah. That's our job as public health leaders, to lead with the science, and then to facilitate locally led solutions to the nation's most difficult health problems. He's committed to not only doing the prevention side, but also delivering higher quality health care at lower cost through patient and community engagement and emphasizing prevention. As the Vice Admiral of the U.S. Public Health Service Commission Corps, Dr. Adams oversees an operation of approximately 6,500 uniformed health officers who serve in nearly 800 locations around the world. They are there to promote, protect, and advance the health and safety of our nation and of the world. Dr. Adams is also focused on building a culture of health and prevention in all sectors. He has created several initiatives to tackle our nation's most pressing health issues, and I want to just name one that he released, Facing Addiction in America, the Surgeon General Spotlight on Opioids, and a digital postcard calling for a cultural shift in the way Americans think about, talk about, and respond to the opioid crisis. His Surgeon General's postcard recommends actions that can prevent and treat opioid misuse and promote recovery. I'm sure he'll share more about this in his notes, and I don't want to steal his thunder at all. But before he comes to the stage, I want to share one little story that I think exemplifies his commitment to finding solutions to this epidemic in a number of different ways, and why his leadership is so important here today. In 2015, while Dr. Adams was serving as the Indiana State Health Commissioner, Indiana experienced an outbreak of HIV that was linked to shared needles and opioid use. It was the largest outbreak of this kind ever in the United States. Dr. Adams believed that needle exchange was an intervention that could immediately have an impact. But as you know, there's not always consensus of what is an effective intervention, and it becomes political. So what did Dr. Adams do? He used science, for one, and he had a beer with the local sheriff. And that was where the outbreak was happening, and they discussed the pros and cons of needle exchange and how that might connect people to needed care. They decided to go forward, and he led the state out of that crisis because he said during his confirmation hearing as Surgeon General that he had to lead with science, but he also had to listen to stakeholders and the people directly impacted and meet them where they were, not have them come to his side. That is pretty much the roadmap for what we're trying to do here today, except for the beer part, at least officially. And we want sheriffs and public safety officials talking to public health and healthcare. And hopefully by the end of the day, we'll have a roadmap that Lizard Brain has captured. So thank you, Dr. Adams, for setting us on that path. And please welcome the U.S. Surgeon General, Dr. Jerome Adams.
Well, good morning, everyone. It is great to be here today. You all can do a little better than that. Good morning, everyone. Good morning. All right, today is going to be a fantastic day. I know that I'm largely preaching to the choir here, but I appreciate the opportunity to kind of set the tone. You know, it's interesting. Folks go through my bio and they mention the MD, the MPH, all the other accolades, but to steal a phrase from the vice president, my most important job is not MD or MPH, it's DAD. I'm a father to a 15-year-old, a 13-year-old, and a 9-year-old. And to be honest, I'm not very happy about the world that at this point we're going to be leaving for our kids. For the third year in a row, life expectancy has gone down due to deaths of despair. I represent the first generation of parents in the last half a century who can't look their kids in the eye and say that you're going to live a longer life than I'm going to live. And that's really why we are here today. And I want to thank, again, Karen, Phil, Mary, for opening things up. I'll tell you, I worked at an academic center for the last decade, and we're responsible for grand rounds periodically. And I was really busy one time, so I brought in our district attorney to co-host grand rounds with me, and it was the most popular grand rounds that we'd ever had. So it was a little bit intimidating having to follow you, Phil, but I think it drives home the point of better health through better partnerships, because in far too many cases, we don't see things through law enforcement's eyes, and law enforcement doesn't see it through our eyes, and we're taking care of the same people at the end of the day, but we have such very different perspectives and levers that if we don't come together every now and then, we're never going to solve this problem. The truth is that our prison care system, our jail system, our public safety system, they provide more of the mental health services than our mental health providers in this country. They deal with more substance misuse than the addiction psychiatrist in our society. And so we're never going to solve this problem if we don't partner with them. And so I want to start things off by asking our public safety, our corrections officers, our law enforcement officers, if you're here, please stand up, anyone in the crowd, and give them a hand. And I very much appreciate them being here. I hope you all give them a high five, give them a handshake, ask permission first, but give them a hug. But really important that they're here, and we need to continue to invite those folks to our table and to go to their table, because I love that some of them are here, but you saw how much they're outnumbered. We need to invite more of them here in the future, and we need to encourage, help them understand that we're all in this together. I appreciate the invitation to hit things off. Mary, again, she's persistent. She's persistent. She told me, we're going to make this work around you, and I appreciate it because, again, as a dad of teenagers, I'm used to being their de facto Uber driver, and so my schedule works around their schedule, and no one ever changes what they want to do according to me. But I want to start off by setting the stage. I know I'm preaching to the choir here, but Mary, thank you for not introducing me as the Attorney General. I will tell you that it's interesting. It seems to happen more often in medical crowds than in other crowds that I get introduced as the Attorney General. And the truth is, I don't want the questions that guy is having to answer right now. So, Surgeon General. Surgeon General. Now, the other level setting that we have to do is, even though I'm a Surgeon General, I'm neither a surgeon nor a general. And there was actually a petition that was going around when I first came into office. There were folks out there who were concerned that the Surgeon General is not a surgeon, and so we need to push him out of office. And true story, weird stuff happens when you get in these positions. But I'm actually an anesthesiologist and a vice admiral. And as an anesthesiologist, I still practice. I was in the operating room last Thursday night. As far as anyone can tell me, I'm one of the only Surgeon Generals, perhaps the only Surgeon General in recent history to still clinically practice. But I feel it's important. I feel it's critically important for us as leaders to not lose touch with what's going on the ground. And I get a lot of feedback from folks when I'm in the operating room. We did a thoracotomy on Thursday, and I saw a gentleman wake up from getting his chest cut open with little to no opioids, and he was awake, he was alert, he was happy, he was pain-free. And it's very important for us to be able to share those kinds of stories, because in far too many cases, people think opioid sparing or opioid minimizing has to mean that you have to tolerate more pain, that it has to be significantly more pain. But again, I'm seeing it, I'm doing it in real life, and so that's not the case. So I mentioned anesthesiologist. I'm also a vice admiral. I'm the head of the United States Public Health Service, and it was started initially by President John Adams, second president of the United States. We're one of the 7 uniformed services, but we use Navy rankings because we were at ports. We were on ships helping make sure diseases like measles aren't imported into this country. And it is so interesting to me that what my predecessors were dealing with well over 100 years ago, we're still dealing with today. And I got to tell you all, even though this isn't a measles talk, I think what's going on right now really epitomizes a failure on the part of all of us in this room. Measles is really interesting because there's no one out there who's a bad guy in this situation. There really isn't. Everyone out there just wants to do what they feel is best and safest for their kids, for their families. And we haven't done a good job of really helping folks understand that we care about them, that we're a trusted resource, that you should listen to us over some of the stuff that you see on the internet. There's a saying, people need to know that you care, or they care what you know. And we like to go out there and tell people what we know a whole lot. But we need to do a much better job of showing people that we care, and then they'll start to listen to us. The measles outbreak is really challenging because 93% of people out there are vaccinating their kids and want to do the right thing, and are doing the right thing. So we're not talking about the 93%. We're trying to figure out how we relate to the 7%, to the Ukrainian community in Oregon and in Washington, to the Orthodox Jewish community in New York, to the Somali community in Rochester, Minnesota. And those folks out there, quite frankly, don't have a lot of faith in us because we haven't done a good enough job of going into their communities and listening to their needs and being servant leaders. And so I think there is a lot of overlap there between the measles outbreak and the things we're going to talk about today. But back to the Public Health Service, we're 6,500 officers, medical officers, doctors, nurses, pharmacists, engineers, environmental health officers, dentists, vets, whose mission is to protect, promote, and advance the health and safety of our nation. We deployed during medical emergencies. We were literally right here in Sacramento last year during the wildfires, providing mental health services and clinical care. We deployed to the U.S. Virgin Islands. I did myself in Puerto Rico during the hurricanes. We've had folks deploy to mass shootings. And so I think it's critically important that you all understand who the Public Health Service is and why I'm so proud to stand before you wearing this uniform. And I'd ask my Public Health Service officers in the room to please stand up. Thank you, guys. These folks are America's Health Army. They're embedded in health departments across the country, and they're going to be literally deploying soon across the country in rapid response teams to help people respond to opioid outbreaks in their communities. Ones like Karen mentioned earlier occurred here in California. But the most visible role of the Surgeon General is what I call the C. Everett Koop role. It's to be the nation's doctor. And in that role, my job is to be the top health advocate, the top health educator, the top cheerleader for health in the United States. And my ultimate goal is to try to give every American the opportunity to live the healthiest lives that they can. One of the challenges, and I've said this to some of you all, is that everybody wants me to make their top priority my top priority. And there are way too many things out there, and there's only one of me. So I intentionally tried to pick cross-cutting initiatives that allow us to lift up multiple priorities. And one of my priorities is improving the health of our communities by making the connection between investments in health and resulting economic prosperity. And this is a whole nother lecture I give, so I won't dig too deeply into it. But do we have our CHEP slide, Dennis? I do want to mention this because far too often we speak about the things that we care about in terms of health metrics and health outcomes without realizing that people don't vote on health. Policymakers aren't elected on health. And that's not my opinion. Gallup polls show that the #1 issue that people vote on, black or white, Democrat or Republican, rural or urban, consistently is jobs in the economy. And far too often that is pitted against health. And when it's pitted against health, health loses every time. They do. So we've got to figure out how we express what we're interested in a way that resonates with an economic and job growth message. And the opioid epidemic is actually an opportunity to do that. I've traveled around the country with Secretary of Labor Acosta. You know, what I see as a public health crisis, he sees as a labor crisis. There's almost 2 million unfilled jobs in this country, more unfilled jobs than there are people looking for work because many folks have checked out due to poor health and especially due to the opioid epidemic. So we have a real opportunity to bring new partners to the table and show that by investing in healthy communities, we actually see job growth, we see wage growth, we see decreased absenteeism, we see increased productivity, we see the things that people care about and that people vote on. And I know we've got a health crowd here, and I'm going way off script here, but I love this story because I was at the U.S. Conference of Mayors, and I had Mayor Bill de Blasio on one side of me and Mayor Benjamin of South Carolina, Columbia, South Carolina, on the other side, in a room full of mayors. And they actually have 2 of the most walkable cities in the United States, and I wanted to know why. And so I asked these 2 mayors, how many of you all ran for office on a pledge to lower your community's hemoglobin A1C rates by 15%? How many hands do you think were raised? Not a one. They didn't make their communities walkable for a health reason primarily. They made it walkable because it increased foot traffic downtown, because they got more business revenue and businesses grew, because property values went up, because it made the community safer. And so we've got to understand that when we express the initiatives that we care about in a way that resonates with people's priorities, we'll get more traction. And so that's why I picked community health and economic prosperity as one of my top initiatives, and why I'll be putting out a report on this topic in concert with local business leaders, business schools. It's why just on Sunday in Aspen, I did a panel with the Philadelphia Federal Reserve Chair, one of the more unique panels folks tell me that they've ever had at Aspen. But it was interesting because folks thought we were an odd couple, and we really were sharing concerns on the exact same problems, just from a different point of view, similar to, again, the law enforcement, the public safety and public health juxtaposition I talked about earlier. Now, my second priority is raising awareness of the link between our nation's health and its national security. And that may seem interesting too, but I picked that because the #2 issue that people vote on across the nation consistently is safety and security. We go to Congress and beg for nickels and dimes, and whenever the Department of Defense wants a new tank or a new airplane or a new sub, they get a blank check. And so if we can help folks understand that healthier communities lead to safer communities and a more secure country, we'll get more attention and we'll get more traction. And the time is right for that too. Did you know that 7 out of 10 of our 18 to 24-year-olds in this country, 7 out of 10 are ineligible for military service because they can't pass the physical, can't meet the educational requirements, or have a criminal background record? And that number is actually probably getting worse, almost certainly getting worse because of the opioid epidemic. So our nation's poor health isn't just a matter of chronic disease 20 or 30 years down the road. We are literally a less safe country right now because we're an unhealthy country. And so I'm partnering with the Surgeons General of the Army, the Navy, and the Air Force in trying to figure out cross-cutting ways that we can lift up health. One of their big concerns is suicides. 20 veterans a day dying by suicides. Well, you know, that's one of the deaths of despair that occur right alongside the opioid epidemic. We need to figure out how we can partner with folks and get to those root causes, those adverse childhood experiences, those traumas that occur to folks that lead them to substance misuse, that lead them to suicide, that lead them to commit criminal acts that then make them ineligible to join the military. And if we bring those partners in, we'll again be a lot more successful lifting up our priorities. And so that's what I chose to focus on. But in the words of the great American philosopher Mike Tyson, everyone's got a plan until they get punched in the mouth. And the punch in the mouth that I've had to deal with during my tenure is the opioid epidemic. And so I'm going to spend the rest of my time focusing on the ways that I'm leaning into the opioid epidemic and that HHS and my office are leaning into the opioid epidemic. But I believe it's a prime example. It's a terrible tragedy, but it's a great opportunity, and it's a prime example of why we need to embrace better health through better partnerships. I just told you people don't vote on health, and that's true. But every now and then there's a blip in the radar screen, Ebola, and all of a sudden people are worried about infectious disease for a little bit. Measles, all of a sudden they're worried for a little bit and then it goes back down. Well, I can go to any neighborhood, any community in the country right now and get a packed house of business leaders, of faith-based leaders, of educational leaders, not to mention public health and medical leaders, to talk about the opioid epidemic. So out of this tragedy, there's a tremendous opportunity if we will simply commit to servant leadership and being better partners, to bring these folks together, to really look upstream, not just look at this as a fire to be put out, but to figure out how we can prevent future fires and to forge those relationships that will allow us to then tackle other more difficult issues in the future. And the opioid epidemic, as many of you all know, is not just pressing for me, but it's personal. My baby brother Philip is currently serving a 10-year prison sentence for crimes he committed to support his addiction. He suffered from untreated mental illness, anxiety, depression that we didn't recognize, much less treat, and he started to self-medicate. He self-medicated with alcohol, with tobacco, with marijuana, and then one day at a party, someone gave him a pill that may have been prescribed by one of you all in the room. Quite frankly, that may have been prescribed by me, because we know that many of us in the medical community, most of us were guilty of over-prescribing, of being over-liberal with opioids back in the day. And that led to a rapid descent into injection of heroin. He stole $200 from a vacated property to support his habit and got a 10-year prison sentence. And I share his story primarily. The primary reason I share his story is because I've often said that the biggest killer out there isn't tobacco, it isn't Coca-Cola, it's stigma. Stigma keeps people in the shadows, it keeps people from asking for help, it keeps people from even acknowledging that they need help. I don't have a problem. I don't have depression. You know, people won't even admit to themselves that they need help because of stigma. It keeps families from coming forward. And so, you know, as difficult as it is to be a public figure and to share a story like that, I think it's important, because if this can happen to the family, the brother of the Surgeon General of the United States, it can happen to anyone. We tend to think of addiction as being those people. And you know what? Those people, my family, managed to raise a Surgeon General, so they did something right. You know, there's probably a whole lot of families out there that, in a vacuum, are wanting to know what my family did right to be able to raise a Surgeon General. But the flip side is they also raised my brother, who now sits in prison with substance use disorder. And so if it can happen to our family, it can happen to anybody. And the other reason I share that story is because it cost, and our corrections officials will tell you this, $150 to $200 a day to incarcerate someone, which means you all, as taxpayers, are going to pay $500,000 to $1 million to incarcerate my brother. $500,000 to $1 million versus $5,000 for a diversion program, $500 to treat his anxiety and depression, $50 for a community resilience program so that he could go to the YMCA and hang around positive influences instead of hanging around negative influences. It just, if you don't care one iota about my brother, if you feel that he did wrong and he's getting what he deserves, I still would hope that you would agree that spending $500,000 to $1 million to incarcerate him isn't a wise use of your taxpayer dollars. And it's money that's being taken away from all the other priorities that we care about. Infrastructure. Gosh, how many people are incarcerated in California, Karen? Oh my gosh. 127,000. Times, let's say we're even spending Let's say we're even spending $100,000 a year on those folks. Think about the infrastructure package we could put in place if we actually had that money available and weren't sending it to incarcerate folks. So, very important that we understand that the definition of insanity is doing the same thing and expecting a different result. We've got to rethink the way we look at addiction, the way we treat folks. We need to help folks understand addiction is a chronic disease and not a moral failing. But we also have to help folks understand that the way they're currently looking at addiction is just really a stupid way, a really inappropriate way. From a very pragmatic point of view, it just doesn't make sense for us to continue to look at and treat addiction in this way. And I've also been on the other side of the opioid epidemic. As Mary mentioned, I was the health commissioner in Indiana when we oversaw the response to the largest HIV outbreak related to injection drug use. She told you the story, but that story, I'm really proud of the way that we went into the community, that we listened to the community. And there are a lot of folks out there, some folks in this room, who criticized me, criticized us for our approach, for not going down there heavy-handed and saying, we know better than you guys. And by golly, I'm going to use my authority as the health commissioner to open up this syringe service program whether you like it or not. And I'll tell you, if I'd done that, the local sheriff would have set up a perimeter around our syringe service program and arrested everyone who came in or left that syringe service program, and HIV would still be spread there. We have to understand that the key word in public policy is public. And though I pledge to lead with the science, we also have to sit down with folks and let them know that we care. Let them know how we're going to meet their needs. Let them understand that we're going to be good partners. And sometimes we got to be willing to accept a half a loaf versus no loaf at all, so that we can move the ball down the field a little bit. And one of the things that I'll be proudest about from my legacy is not simply the syringe service program in Scott County, Indiana, but the fact that after that, Kentucky went from 0 to 50 plus syringe service programs, that federal law was changed in regards to funding for syringe service programs, that little spark provided a change in the way people are looking at harm reduction all across the United States. But you know what? It never would have happened if I went in there waving my New England Journal of Medicine or my JAMA articles and saying, you people are a bunch of idiots, I know better than you, take these syringes and I'm going to fix everything. So very important that we remember that. I want to go off into a little bit of a different area. CDC reported 70,000 lives taken last November due to opioid overdoses. A person dying of an opioid overdose every 11 minutes. So Karen set us up for this, but I want to ask you guys, raise your hand if you know CPR in this room. Great. Raise your hand if you carry naloxone with you everywhere you go. Anybody see the difference in hands? And I'm supposed to be preaching to the choir here, right? The chances are greater someone's going to come in that door right now. Anyone kind of notice as we were walking down the street here? The chances actually here, right here where we are right now, are much greater that someone's going to walk in that door and say someone's overdosing out on the street or out in the bathroom outside than they are that someone's going to come in and say, we need you to come help with CPR. And you saw the difference in whether or not people were prepared. And this little guy right here is a whole lot easier than CPR. It's literally that easy to save a life. That easy to save a life. We need more of you all to step up to the plate to walk the talk. And I do want to thank you all for helping us spread the word about naloxone, because after our advisory came out last year, we now have naloxone dispensing from pharmacies up over 450%. We have saved lives. You guys have saved lives. But we've got to continue to walk the talk. We know that there's compassion fatigue going on out there. We know that there's still stigma related to people being willing to carry naloxone. I want to tell you what else we're doing to respond to the opioid epidemic. We're working with healthcare professionals to improve safe prescribing practices post-operatively and in primary care settings, and to minimize diversion by using resources like the CDC guidelines for prescribing opioids for acute pain. Thankfully, opioid prescribing is down 22% across the country. That's the good news. The bad news is that 62% of people who misuse opioids say they misused opioids to treat chronic pain. We had a crisis of acute and chronic pain 20, 30 years ago. We threw opioids at it. It didn't work. We're pulling the opioids back, but we aren't adequately replacing the opioids with something that will treat folks' physical and emotional and mental pain. And so, again, we're just going to keep playing whack-a-mole. I was in Seattle, and now they're seeing an increase in meth use. So you should certainly applaud yourselves for decreasing opioid prescribing and making sure that's done in an appropriate way. But you shouldn't be too heavy-handed with that pat on the back unless you're simultaneously tracking that you are increasing the availability of alternatives to provide proper pain management for folks so that, again, we aren't continually chasing our tail. And I'm going to go off on a little sidetrack here because, there's a saying that those who don't study, don't learn from history are doomed to repeat themselves. Folks know the Office of the Surgeon General because our warning label's on the side of a pack of cigarettes, right? Well, 50, 60, 70, 75 years ago, tobacco was marketed as a treatment for anxiety and for depression. We were told that it was safe for you. I even have ads. I collect classic ads from medical journals of doctors smoking. 9 out of 10 doctors prefer Camel, we medically endorsed it. It was prescribed by folks for all sorts of ailments out there. And then we spent the next 50 years trying to clean up our mess. 20, 30 years ago, we were told that opioids were safe and effective for whatever ails you. And doctors prescribed them like candy. And now we're cleaning up the mess. We're now in an era where folks out there are saying that marijuana is safe and effective and good for what ails you. And it's magical. It's magical. It'll treat everything. There's no harm. And you've got communities here in California where 1 in 5 pregnant women are reporting that they're using marijuana during their pregnancy. We know that in states that have legalized marijuana, even for medicinal purposes, that youth attitudes about the dangers of marijuana are going in the wrong direction. And this ain't your mama's marijuana we're talking about here. It is a fundamentally different, much more potent product. And I am worried that we're going to be doomed to repeat history over again if we don't pay attention to this larger umbrella of substance misuse out there and stop switching from one thing to another to another. I want to say that we also need to do a better job, and my office is trying to reach out to folks and support increased provision of medication-assisted treatment services. And Karen, Dr. Smith, talked about that. I have an article out in the ACOG Green Journal this month calling on all OBGYN providers to all OBGYN training programs to commit to making sure no one graduates moving forward without being data wavered. And I did that because I feel the biggest gap exists for women who are pregnant with substance use disorder. The OBs don't want to take care of them because they have substance use disorder. The addiction psychiatrists don't want to take care of them because they're pregnant. And there's nowhere for them to go. I'm planning on moving from there to our ER doctors out there. I've talked to drug dealers. You know the best place for a drug dealer to hang out, according to the drug dealers? The ER parking lot and the jail parking lot. Because we put people into acute withdrawal and then we send them right back out without a warm handoff. And we need to make sure we're doing MAT induction in the ER settings. I gave grand rounds at UC Davis yesterday. You know, back when I went to medical school, you'd never think of having someone finish medical school without knowing how to monitor, how to diagnose hypertension and how to treat basic hypertension and when to refer folks who have high blood pressure. Why? Because many folks in society have high blood pressure. Many of your patients are going to have it. Even if you're a dermatologist or a radiologist, you need to know how to recognize it, how to diagnose it, how to do screening, brief intervention, and referral for a more appropriate treatment, right? Well, the reality is the folks coming out of medical school today are going to have a significant proportion of their patients who are either at risk for or who have or who are recovering from substance use disorder. So we are doing them a disservice if we don't create an environment where they're coming out prepared to recognize, to diagnose, to treat. And so my hope is that we can very quickly get to a place where every person, when they're leaving medical school, is getting the appropriate training to do screening, brief intervention, and referral to treatment for folks with substance use disorder. And to answer a question that I commonly get, I think that's the solution for getting rid of the, or for making more providers available, and for ultimately getting rid of the data waiver. Now, I want you all to hear me when I say this. A lot of folks say, well, we want you to get rid of the data waiver first. As a physician, we all admit that we don't get enough training in how to properly recognize and treat people with addiction. And we also know that Suboxone is one of the most commonly diverted drugs out there. So I'll just be honest with you, on a federal level, we're worried about taking away the little bit of training that people get before they are actually able to go out and prescribe this highly diverted medication. But we do need more people to feel comfortable writing for this, and the way that we get there is if we graduate everyone from medical school and we can clearly document that they've gotten well more than 8 hours of training in how to treat people with addiction, then we can stand in front of Congress with a straight face and say we no longer need the data waiver. That's the approach that we're looking at from a federal level and that I endorse. And I ask all of you all to join me to help folks understand the importance in our medical education training for doctors, for nurses, for pharmacists, for everyone to get more training in how to properly recognize and treat people with addiction. The final thing I want to mention is my opioid postcard. It lists 5 steps that everyone can take to respond to the opioid epidemic. It's a digital postcard fashioned after C. Everett Koop's pamphlet that he sent to every household in America called Understanding AIDS. Why? Because he was dealing with a crisis of stigma, a crisis of fear, a crisis of folks pointing fingers at each other. And he wanted everyone to understand the role that they could play. So these are the 5 steps that I think every American can play to respond to the opioid epidemic. And I need you all to share this. Go to surgeongeneral.gov, take a picture, share that on your social media sites, because I don't have the money to send one to every mailbox in America, and my kids told me no one reads their mail anyway. So the way we're going to share this is digitally, and I need your help. Now, I want to close with a couple of challenges to you all. I challenge you to think of at least one new partner whom you can invite to your table, and just as importantly, whose table you can go to. Preaching to the choir again, you all have heard of health in all policies. My problem with health in all policies is we tend to think of health in all policies as it's our job to ram health into every other policy. My idea of health in all policies is that health should be present at the table when all other policies are discussed. And that means we've got to go to their table, we've got to listen. We've got to listen to their priorities and then help them understand how we can achieve their priorities. And I know I'm running out of time, but I want to give you another story. We were trying to get the park services to go smoke-free. And the park services said to us, we agree with that in theory, but we don't have the money, the manpower, the ability to go and police the parks and be the tobacco police. You know what? When we went to them and pointed out the fact that, hey, you all have lots of money to prevent forest fires, right? And number one cause of forest fires is people smoking in these parks. So let's not look at this as a health intervention. Let's look at this as a forest fire prevention intervention, and we're going to help you get there. All of a sudden, when we sat at their table and understood what their concerns were and showed them how we could help them achieve their concerns, we had a lot more success. So go to their table, make a new friend today. Make sure you leave here with a couple of new contacts, just as Mary mentioned. Second, join me in raising awareness about the use of naloxone. And, we also need to think about how we can make naloxone the first step to recovery and not just the over and over and over again Band-Aid. A lot of our public safety officers, quite frankly, are burned out, compassion fatigue. They're seeing the same people 7, 8, 9, 10 times. I don't blame them for being frustrated. We've got to step up to the plate and make sure we're providing peer recovery coaches. We're providing warm handoffs. We're helping them figure out how that naloxone becomes a bridge to care and not just one more opportunity for folks to continue down the pathway of addiction. I think if we do that, if we show them, hey, we're going to help you, then they'll be more willing to carry naloxone. If we share those stories of hope, of success, of recovery, of people who were revived and then were able to get into treatment, and then are in long-term recovery, and then are peer recovery coaches like some of the folks in this audience today who I've met, then they'll be a lot more willing to carry naloxone, and it will help us destigmatize it. And help me put an end to stigma by sharing your stories, sharing my digital postcard. I want to finally ask you to make sure you share your best practices, publish your work. The Journal of the Surgeon General is public health reports. I want to encourage you to think about publishing what you're doing in there, because all across the country, and I travel all across the country, there's great innovation going on, but there's also a lot of people trying to recreate the wheel over and over and over again, because we aren't sharing our best practices. And that's why today is so very important. It's so important that you're here verbally sharing your best practices and learning from others, but publish some of these best practices in journals like Public Health Reports, so that, again, other people can learn across the country from what is going right from you, from your point of view. Also learn from some of the obstacles that you faced, so that they don't run into the same obstacles over and over again. Continue to be the innovators, the educators, the communicators, and where necessary, the agitators that will create a healthier tomorrow for all Americans. And thank you so much for letting me serve as your United States Surgeon General.